Welcome to MAP, the bi-weekly market access podcast hosted by me, Dr. Stefan Walzer. I am the innovator of Market Access 4.0 and a health economist by training and working in the fields of market access, reimbursement, pricing, and health economics since 2004. Discover Market Access 4.0 and unveil the future with our innovative solutions. Max Insights, our fast and easy AI-based reimbursement planning platform. Dobo, our new revolutionizing way of creating reimbursement dossiers across the globe with the first and only dossier writing AI bot. Cubo, our new AI-based objection handling platform. And Waffle, train with Waffle's virtual reality genius in an immersive environment and with an AI-based counterpart. We are Market Access 4.0. So check out our website, marketaccess4-0.com. And now let's dive into the current discussions, processes, and trends in market access across the globe. Welcome to another show of the Market Access podcast. Today, we're trying to cover a bit more broadly market access, and we take health as an investment as a core basis of the discussion. And I'm very happy that I have, I would say, really experts to the topic with me today. Welcome to Malina Müller from the WifOR Institute. And if anybody would not know you, of course, Malina, quickly introduce yourself. And of course, as well, if you want, the WifOR Institute as well.
Yes, thank you. Thanks for having me in general. So I'm Malina and I'm leading the Health Economics Department at WifOR Institute. We are an interdisciplinary research institute with a focus on impact studies, labor studies, and health economics. And I have been now with WifOR for almost 10 years, and my background is in social sciences with a focus on statistics and economics, while now I consider myself a health economist. And we are in general a very interdisciplinary team, not only at WifOR, but also in our health economics department. And what brings us together is a shared goal. And that is exactly what you said, making the value of health visible from a macroeconomic perspective. And I'm passionate about rethinking how we talk about healthcare. And that is not as a cost, but as an investment, because better health doesn't just benefit the individuals, but it also drives economic growth, supports social systems, and strengthens entire societies. And that's why I'm here today, because I'm convinced it's time that we start treating and discussing about health, what it is, and that is the powerful engine for prosperity.
No, absolutely. And I can only agree with you. I think just even with the first words what you have just said. But still, if we look back and maybe look into the decisions made by a lot of stakeholders in different healthcare systems, not only in Germany, but I would say across the globe, I think health is rather still be seen as a pure cost center, at least in the discussion. And I would even say it's not only from a macro level perspective. I think even if you go into, for example, price negotiations for a new drug or for a new procedure, you still have that kind of, let's say, discussion. It's all about the price. It's all about the cost and the impact of that. So let us maybe try to dismantle that a bit today, because of course, it's rather simply said, health should be seen as an investment. So maybe could you explain that a bit more in practical terms? How would you see health as an investment? You said already a couple of small things, but just that people who have not thought about that kind of concept, that they could follow the discussion we might have in the next couple of minutes.
Sure. So treating health as an investment means really shifting the way we think about health spending. And as you said, not only as money gone, but as value created. And we already apply this thinking in other sectors. For example, when a government builds a bridge, we don't look at the construction costs alone. We ask what it unlocks: better trade routes, reduced commuting time, stronger local economies. We see it as an investment because it enables other forms of growth. And health works the same way. It enables people to work, care for others, and contribute to society. However, we still treat it, as you said, like a cost center and not a value driver. But if a system invests in prevention or chronic disease management, sure, we first have to spend this money, but this money is not only, let's say gone, but it is avoiding future treatment costs. But more importantly, it is also keeping the people in the workforce. It is reducing pressure on caregivers, and it is lowering demand on hospitals and long-term care. And this is what we need, especially in an environment of limited budgets and aging societies. Maybe, let me bring in a concrete example. We conducted a study in Mexico where we looked at the impact of early intensified treatment for type 2 diabetes. We considered a 10-year period, and it led to around 30,000 avoided complication events. And those events translated into social gains of roughly 54 million US dollars through recovered paid and unpaid work. And this is a significant return in terms of productivity and economic contribution. And to put it into perspective, that is roughly equivalent to the annual salaries of over 10,000 minimum wage workers in Mexico. And I think this is highlighting the tangible, and this is important, it is tangible, economic value of prevention-focused healthcare. And this is what we must do. Spending on health doesn't just disappear, it generates return. It leads to longer lives, stronger economies, and more resilient social systems. And this is exactly what we do at WifOR, measuring those returns. We quantify how those better health outcomes contributes to productivity, labor force participation, and the long-term stability of economies. Because healthy populations are the basis for everything, and they are more adaptable, resilient, and in the end, economic active. And this investment logic aligns also with broader macroeconomic goals economies have. And this can only support the idea that healthcare should be part of national growth strategies, especially in aging societies where we're facing shrinking labor forces.
Yeah, no, I can only again agree. I think that makes a lot of sense. And I mean, especially also when you think back how and why healthcare systems were basically kind of invented by business owners a couple of years ago, or 100+ years ago, right? It was basically to see that their workers are healthy because then they are more productive. Very simple thing. But I think a lot of times we still forget that. Whether it's maybe the messaging in the direction of stakeholders and also the other way around. Of course, if stakeholders have their budget in mind, and of course it's their task to, let's say, have as well their budget under control, which brings me a bit to maybe another interesting kind of question. I mean, it was very really impactful to hear also the analysis you have just brought into from Mexico. I mean, with the events avoided, which brought it, as you said, 45 million US dollars of kind of cost savings, or if you turn that, let's say, additional kind of investment into the system or the society. I mean, this was probably because you have spoken about avoided events for those type 2 diabetes patients. That was probably as well for a longer time period, right? The analysis that was maybe for 10, 15, 20 years. So how do you explain that to maybe a stakeholder who's looking for a budget, who is maybe just for a year or 2, or maybe even 3 years kind of a time frame? Is that as well a bit of an issue? Because I think in the long run, they might as well agree, but maybe the investment is just there for the first couple of years, and then you see the benefits only later on.
Yeah. True. This is a very good and valid point. And I think this hinders also, how in general broader stakeholders or set of stakeholders see spendings in the healthcare sector. First, we have siloed governance structures. So health ministries focus on delivery, finance on cost containment, and they rarely align their goals. And you already mentioned the time horizon, and overall political timelines are short. So health investments often show returns over 10 or 15 years, especially when we look at the health effects, while most decision makers operate on 4 or 5 year cycles. Mm-hmm. And nevertheless, the health economy is already benefiting in the first year or in the second year, because it is also an investment really in this sector. Mm-hmm. is not only then triggering economic effects in the health economy, but also in adjacent sectors. So we have, for example, just recently published a study together with Rifat from Harvard, where we analyzed the economic return of cancer investments in Commonwealth countries. And depending on the countries, the effects, they differ, but we could show that the ROI is already positive in the first 3 years. There is a direct economic benefit. We are not talking now about the health benefits that will impact later on then also the labor market and productivity. No, because it triggers, let's say, along the whole value chain, economic activity. You have to buy, let's say, those treatments. They must be applied in practices or hospitals. And this also generates jobs and economic, let's say, return. So I would tell them, please have a look at this study. Yeah, you always think that you're only getting a return in 10 or 15 years, but you are already getting it earlier. And besides that, asking the question, okay, you are not going to invest in something that, however, also your voters will benefit later on. This would be maybe a little bit more of a confrontative question, but you can, or we should really ask such questions as well.
No, I agree. And I mean, we have those decisions as well when we maybe speak about longer term kind of impacts also from a health intervention, like, I don't know, a vaccination or something like that, right? Where, of course, as well, systems are already paying for pieces, treatments, procedure, whatever it is, which has a special impact in a longer kind of time frame. Anyway, if we bring that still a bit further down, let's say to a micro level, and maybe not so much, let's say, from a health politician's perspective, I agree. I mean, a lot of times that's also a bit of perception, long-term career goals, also the kind of the party itself, etc. I think that's very something we can move a bit aside. I think there are as well different kind of discussions we could maybe have. But if we maybe move a bit into more like market access or reimbursement decisions, I mean, the frameworks are kind of given. When we think about Germany, I think it's pretty much clear. Most of the other, at least European countries, is also quite clear. But still, I think also in those frameworks, I think things can and should change and be reformed, maybe, especially when we think about that. And I think especially very important, maybe for everybody, as you have just alluded again, towards the return on investment might already even be positive in the first year, or at least the first years. Meaning, how could that as well potentially have an impact on HTA frameworks or also decision making? Is there anything like a frame or a metric, what you would maybe be thinking, which could also be included in such of decision makings?
I think there is not yet, or maybe there is never a one size fits all approach. I think the most important thing that we have to start with is, let's say, the willingness to discuss this, to really wanting to reframe health as an investment and agreeing that it has the potential to fundamentally shift how we think about pricing and access to innovation. We are starting to see that, in some countries like the UK and the Netherlands, there are efforts to include broader societal perspectives in HTA, especially where we have conditions with high productivity losses. But overall, market access decisions are still dominated by those short-term budget considerations. And I think with the value frameworks that we have now, it is not yet super clear how you could do that or what you should include. And I agree with you that this needs to change. And in order to reflect the full return on health investments, HTA and pricing frameworks need to evolve. And that means first, really moving beyond narrow healthcare system metrics, not only looking at the hospitalization rates or the drug costs or the short-term survival rates, but to include value dimensions like the productivity gains, reduced caregiver burden, and the increased economic participation, because they are measurable and they are meaningful. And they are at the moment left out of the formal assessments because exactly what you said, we do not have yet a super fit framework. And at the moment, it falls outside the payer's, let's say, immediate budget silo. However, there are already ways how you can capture it. And I think what often, let's say, opens the discussion is to come from the, let's say, other end of the question. And this is, okay, what does it cost us to not do this? When we want to measure the return on investment, we must, sure, in general, focus on how improved health outcomes translate into those then tangible economic and social gains. So the start point must always be the health benefit. This is something that we are already, let's say, clear when we talk about frameworks. And then we must go beyond also what is saved in treatment costs and look at how it affects people's life and the broader economy. And there are frameworks, also frameworks that we apply to, for example, capture the socioeconomic burden of diseases. And this can include lost productivity, informal caregiving, and the reduced participation in the labor force. And those burdens aren't always visible in health budgets, but they are very real economic losses. And I think when we start quantifying those, we can generate awareness that this is a real economic loss and that some proportion of those losses are due to inaction. For example, we found that migraine led to economic losses in Europe ranging from 35 billion euros in the Czech Republic to over 550 billion euros in Germany over 10 years. This is up to 2% of the GDP. And this is to some part driven by underdiagnosis, lost working days, and long-term absenteeism. And it is feasible to capture that. We need also, let's say, I call it now the HTA bubble, to sit together and discuss about what is feasible with the frameworks that we already have. We are talking for now years about, for example, the ISPO value flower. But we are not, let's say, moving beyond with regards to, let's say, standardized frameworks. What should we capture? And without that, we can also not, let's say, talk about the critical points that are really there. And I will not say that we do not have inefficiencies in the system and that we must be really careful what we also demand to be included, because having said that, I think we must broaden how we view spendings in the healthcare sector and consider it as an investment rather than a cost. Let's say, the question of equity, for example, is there. So what do we do, or how do we handle it when people are not working? How do we value then the health, for example, of children, because their health is not, let's say, less important or less valuable? So long story short, I think there are frameworks and we can build up on them, but it is, let's say, not helpful when we are all applying different frameworks that capture, let's say, the either socioeconomic burden or the social impact or the return. It must be clear, what do we want to capture? What are the shortcomings of the frameworks that are available? And how can we improve? How can we move towards really a common understanding?
No, I agree. I mean, listening to you, I could maybe as well think of making it quite simple, that maybe the messaging by the industry, for example, when we think about new products or new therapies, is simply not broad enough. Because, if we just speak about survival or, I don't know, less adverse events or whatever, that's of course true, but it's maybe not capturing everything. Because, if you just take the next step, I mean, then you're basically in the discussion you just brought up, right? What does it really ultimately mean? Not only from a patient perspective, but maybe as well beyond that, right? Beyond the individual, so for the society.
Yeah. And I think, so from my perspective and in my experience, I find it somehow a little bit strange that outside the health bubble, health isn't really on the agenda. So the, let's say, general population might be now talking about the climate change, but we are not really talking, let's say, also with the general population about the meaning of health and what does it capture? What could you maybe even get if you would also speak up? And this is also due to the fact that we are not, as let's say, people who are in the area of HTA or consider ourselves as health economists, we are not yet super good in translating it into understandable language. Mm. Our guidelines and the HTA assessment rules, they are valid, but nobody who is, let's say, not in this area or really specialized can easily follow. And when you remember the example that I brought in the beginning with building this bridge, people might then understand why in their city a bridge is now built or a road, because there we communicate, let's say, the economic benefit and what it means. I never see this or hear this when we talk about health. People might be frustrated because they cannot get an appointment at a specialist very soon, but that's it. And so I agree. I think all stakeholders are not yet super good in communicating what it really means or what we could generate if we would see it with a different lens.
Yeah, no, I agree. It reminds me, we had a project here in a local region where we have just helped the whole region to, let's say, reorganize the management in mental health, which is more a kind of procedural kind of pieces. But interestingly, I think we have also been connected not only with physicians, with patients, but also the local politicians. And their key question was always, so which kind of impact would that really have on all of us? If we would need to approve, let's say, the next, I don't know, a couple of 100 or 100,000 or millions of euros for the next steps after the kind of concept, right? And I mean, the first thing what physicians told us, because we're more managing and trying to get the different views as well in there, but physicians, especially, let's see, psychotherapists and the like, they basically always said, look, it's very simple. Tell them if they want to have the next kind of mentally ill persons going crazy somewhere in their city. I said, oh, interesting. And it's as simple as this, right? It rarely happens, but if it happens, it has an impact, and it might even be shown wherever in the news and the like. But this is basically as well just the next step, where you just say, I mean, we need to do something for those patients. But on the other hand, I think it's also, let's say, probably the example which shows how it or where it doesn't work as well. Anyhow, I think I brought in industry before. I was also just writing down while you were speaking. I mean, if I followed the reimbursement path in a way, in the German context, is the AMNOG, right, for drugs, and there we have the GBA as a key stakeholder. And GBA is especially looking for patient benefits, which could as well, when we would be thinking and speaking about a framework, I would say an ideal first step in that whole kind of communication area, because they insist in the patient benefit. But why not just insisting on the next level, right? Which kind of impact would that have on a societal level? And maybe it's not mandatory at the beginning, right? Maybe just optional to, for example, include there. But it might be quite interesting as well way for both sides, industry and as well the payers, to argue maybe for a given amount of additional budget, maybe call it like this. So not only, let's say, speaking about the price, but I don't know. I guess nobody has really thought about that kind of next step as of now.
I think this would be an important next step. Maybe, as you said in the beginning, not mandatory, but why? So I'm saying we have to see spendings in the healthcare sector as an invest. When you're talking about invest, you must be able to really capture the return of those investments. And yes, we do this the best we can with literature research and modeling, but it would be much more easy if we would have a robust data infrastructure to track it to track the long-term economic outcomes of health interventions, or maybe in the first step, just capturing the impact on the patients with regards to productivity or the impact on their caregivers in a much more systematic way. We have even questionnaires like WPAI or caregiver surveys that you can integrate also in the clinical trials, but it is not happening too often. And then we have simply a database that is not good enough to do all the calculations, or the insecurity is just getting bigger. And I think this is what we need. But for that, and this brings me back to the other point I said, there must be the willingness to really work on that together. Only when, let's pick now AMNOG or GBA, we need the openness from them to say, okay, let's do it. Let's go one step further, maybe just for selected case studies. As I said, maybe for chronic diseases where the impact on productivity or labor is highest. Let's do it in a more systematic way. We will not change the system overnight, but I think we must start now, because we are really seeing an increase in our spendings in the healthcare sector. And when we talk about also preventive care, it is always considered, again, only as something that will increase our spending without seeing that we are not investing now. We have to pay later on, and maybe even twice. So when we are not investing now, we are maybe losing twice, because we have the spendings already now for treating a disease, and we will have it then in other social security systems as well. Yeah. And this, let's say, also multi-sectoral approach is, I think, what we needed more. Because in the end, everything is related, and we are seeing, at least in the main Western countries, we see a shortage of skilled labor, we see greater care dependencies, and we see that the system cannot tackle it any longer. So there is from my point of view, really the urgent need to react now, because otherwise, I think it will not work any longer. Or we will definitely have to increase the spendings for the healthcare sector, but without having a plan how we could reduce it in the future.
Yeah, exactly. And I mean, ultimately, if you look back on the last, I don't know, at least 20 years or whatever, I think nobody has really been able to manage the cost in the way they wanted to manage it, right? Whether this was the right approach or not, doesn't matter. Nobody was basically successful. The only kind of, let's say, point where you see a kind of positive impact is if the economy is doing well. Hence, you have more kind of revenues to be spent in a way. But this is, again, going back exactly what you said as well a couple of times. What is as well a key part of the equation for the economic growth is, of course, having healthy workers in the workforce or the labor force as well.
Yeah. And let's bring in another example, cervical cancer screening. We have a use case in which we modeled a really structured pap test screening. And we could find that every €1 million invested generated nearly 2 million in gross value added and created around 5 jobs when we do it for the whole population. And we are not only generating this economic contribution, but we are also preserving 33 million hours of paid and 11 million hours of unpaid caregiving. And when we sum this up, or when we monetize this, it sums up to 328 million of euros. So this is a massive return that goes beyond clinical benefits. And I would say that instead of asking, can we afford it, let's say, to invest in this PEP screening, we should ask, can we afford not to invest? And I see that other countries are really open for such studies, or countries that are at the moment trying to implement such a screening or the vaccination for HPV, that they look at those figures and say, wow, this is something we can work with. And I think we must also broaden really the view from a, as I said, macroeconomic perspective, because in the end, this is a euro sign. And stakeholders, unfortunately, understand this better than just saying, listen, we save XY lives.
Yeah, no, that's a very good point. And I mean, I also just noted that I think if you have a look on some of the countries across at least Europe, we have some, especially maybe in Scandinavia, who are also looking a bit more on a social impact, especially when it comes to health economic evaluations they run, that at least part of the indirect costs, what you also have spoken about beforehand, can be included there. But still, it's just a small portion. It's only very few countries. And I mean, I'm not an expert to say that this has still a kind of positive impact finally on maybe pricing and reimbursement decisions, but maybe it gives some hope that this could potentially also have an impact, at least from a European perspective. As we know, I think JCA is currently ongoing from a European perspective. And maybe that is the way how to include that, at least indirectly, and then potentially countries could also pick it up. But brings me a bit as well towards the future outlook of it. I mean, if you would be, or if we would maybe be sitting here in, I don't know, 5 years or maybe 10 years time, how would such a kind of, maybe call it health investment oriented market access system ideally look like from your perspective?
Okay, so if we could build a market access system from scratch, what would it look like? So first, I would say we have to measure this value just to make it clear. So the value beyond the health system. And that would really mean, as we discussed previously, including long-term productivity gains, caregiver relief, and broader societal returns as standard parts of the value equation. And another important point would be to build on cross-ministerial collaboration, not just health payers at the table, but also finance, labor, and social affairs. They should work together to allocate investment where it delivers the highest returns. And I would embrace also a long-term thinking. So interventions should be evaluated not just on 1 year budget impact, but on 5, 10, and 15-year horizons, allowing investments in prevention, innovation, and workforce health to shine, because then you can really plan. And yeah, I would say that those would be the main pillars. This is the kind of thinking we need. A system that is a little bit more agile and future ready, really looking also beyond, let's say, the 1 year time horizon, and also built to reward long-term value and not just the, let's say, short-term affordability, because this year not, let's say, much more money is available. Because only when we really see it as an investment, and investment doesn't mean that we are only looking at the short-term period, then we can really change this perception.
Yeah, I think that was a good couple of final recommendations if anybody would be listening who is maybe speaking to politicians in general, not only health politicians. And I think just as a very short final side note, I would say it's possible that also politicians think long-term. I mean, we see that now with defense investments, for example, just in the recent couple of months. So it's possible, but I think the incentives would probably need to be there, or the risk to maybe lose something more than just, let's say, a 1 year budget or something like that.
True. And I think the question is also, when is a crisis or perceived as a crisis? And with defense, okay, we see it directly. The investment is then there. It is considered as a crisis. And I also do not want to, let's say, panic. But what we see in the area of health is, from my point of view, really, really close to a crisis. But I think it also is part of the story to be, let's say, honest, because we have those geopolitical changes and at the moment tough fiscal realities. But from my point of view, this even underlines why we need smarter and return-oriented health policies, because those investments aren't luxuries, they are pillars of economic resilience. And this is the way we should go.
No, absolutely. And I think just last word, I think when we just look back, I think to your great example from the economic impact of cancer or investment in cancer treatment or procedures, the return on investment was already there positively in the first year. So having that in mind, to also link it what you have just said with the, let's say, crisis also in healthcare and the financials of healthcare, I think then that is probably something what decision makers should have in mind when deciding for the next steps. Malina, that was great fun. I learned a lot. Thank you.
Thank you.
And talk to you soon in the future.
Yes, talk to you soon. And thanks for having me again. Bye.
Health as an investment. Big topic in a way, and as I have also spoken quickly with Malina beforehand, it should be rather the first lesson in any kind of health economic course at the university. But this is just the start, and if we then follow and go into the kind of next steps, especially in health policy and everything around it, it rarely happens to be the case, especially when we think and discuss about pricing and reimbursement. I think key thing is, of course, still the siloed structures of decision making and budget allocation. I think this is a key part, and of course, as well linked maybe to that as well, is as well the short-term thinking of decision makers. Anyhow, I think what Malina and her team at the WifOR Institute has shown a couple of times now is that return on investment into health has already an impact, a positive impact in the first 1, 2, or 3 years. So it's not only that we would basically need to wait as a system for a positive impact for 5 or 10 or 15 years. Of course, maybe the impact could be even bigger than, but those kind of investment can already be seen in a short time frame. Important is anyway, of course, when we think about health as an investment, that the health benefit for a single patient is the first step. Hence, it's nothing different to what we see currently in terms of evidence generation. And thereafter, it might then be, of course, linked as well to treatment costs. And with that, of course, then the patient impact, which could then lead to the social impact of that. There are already examples available not only for individual studies or product, has also the impact, for example, in some areas like in Sweden, Netherlands, some other kind of countries, for example, especially in Scandinavia, who, for example, also include indirect costs, but it has not been seen, let's say, broadly across the especially major systems in the world. Let's just see if anything like the recommendation Malina gave will be changed in the short term. And of course, I think very important keeping also in mind, probably, and that's, I think, one of the key takeaways I as well have in here, if you, for example, do not pay in the short term for health, for example, not paying for prevention, because that might maybe as well increase cost in the short term, these payments might be coming later on and probably even with a higher impact. That was an episode of MAP, the market access podcast provided by Mars Market Access and Pricing Strategy, which is your healthcare consultancy in the German-speaking markets. MAP is available every second week with a new episode, so watch out. And in case you might have questions, contact me directly and or visit our website on www.marketaccess-pricingstrategy.de.